Thank you very much for your welcome this morning, and give you my greetings from Australia, and apologise that I'm not in Singapore to participate in person, but send my wishes to colleagues and friends in Singapore. My discussion this morning's on the need for precision in the management of hypertension and backgrounded on clinical and physiologic imperatives. It represents a paper and study work that we've been doing quite some time with Stefan Carlier, Alessandra Scalia from Mons University, and Joe Briley, who's in paediatrics at Great Ormond Street in London. I started with this image because it demonstrates a very early recognition by the inner canon of Yellow Emperor in 85 AD that blood pressure and blood flow are actually quite interdependent and related clearly. They measure the pulse, which of course is the blood flow, the blood pressure, and yet they recognize, and I love the poetic expression, the pulse is the palace of the blood. It's governed by the heart and commanded by the chi, which is the vital energy, which for later day physiologists would call the systemic vascular resistance. So it's an adequate place to start, and I think the lessons learned from that observation carry through and imply or support the proposal that I make today. We know hypertension's elevated cardiac function and or vascular constriction, represented or measured by elevated blood pressure. It's a complex system, homeostatically regulated by the autonomic nervous system, renin-angiotensin, aldosterone, cardiac natriuretic peptides, vascular endothelium, etc. And it's mediated by the interplay of baroreceptors, chemoreceptors, and thermoreceptors. So it's a complex field, and simplifying it to a measurement of one parameter is probably fraught. Let's contextualize it. It's a global risk factor for human death. Number one risk factor for human death and morbidity. Worldwide, 1.28 billion people. 50% are unaware they have the condition, although 33% of those over the age of 30 to 79 actually have the condition. But more damning than that is that less than 50% are treated. And of those who have hypertension and know about it, a mere 25% have their BP controlled. So less than 50% of those people who are treated have successful control of their BP. So we also know the cost of managing hypertension for the US alone in 2018 was $316 billion, and that the incidence of hypertension, morbidity and mortality continues to increase. So we really have a predicament. We manage this relatively ineffectively. It's an increasing pandemic, and we need to perhaps review what or how we can manage hypertension better. It's common, dangerous, and costly. If we look here at these global data, as I said, a third of adults worldwide have hypertension, and it's not isolated to one country, and there's no country that is immune from it. Less than 50% of those treated for hypertension achieve BP control. And to me, this is the alerting factor of all of this, because what it says is that our approach to this disease, which is almost ubiquitous, is modestly effective at best and ineffective at appropriate assessment. And if we look over time, the changes, the incidence has increased and the percentages haven't changed very much. So despite the fact that we've done an incredible amount, the clinical imperative to improve hypertension care is established. The dismal global outcomes persist despite 20 years of intense focus on prevention and improved care. Hypertension, the publication of multiple global practice guidelines, unprecedented public health spending, and the marketing of a constellation of evolving pharmacotherapies and monitoring technologies, we remain with very poor outcomes. So there is an opportunity for a review of concepts and practices to improve outcomes in this pandemic condition. BP targets are used to define and treat hypertension. BP monitoring is the most common clinical investigation in medicine. High and low BP are used as an indicator of health and guide for therapy. Yet 1 in 159 medical interns demonstrated proficiency in BP measurement. The average result for those folk was 37%. So the most basic of processes and the most fundamental and probably the most influential at a fundamental level is performed universally quite poorly. And there are lots of reasons for this. If we look at the physiology alone, it varies across space and time, as Einstein would say, where you measure it and when you measure it. And there is a natural background regulatory variability. And so depending on where you measure and at what time you measure, what results you will get. It also spreads your standard deviation of any number of measures that you make to use as a reference point for normal values. And the concept of normal values, while quite powerful, are also somewhat redundant when we start talking about precision medicine. And that's taking care of each individual rather than a collective population. Another thing that's quite interesting in all of this and published in the Journal of Hypertension, meta-analysis of multiple texts identified 29 sources of empirical error for measurement of blood pressure. And the average increases were greater than, in 79% of cases, increased systolic blood pressure by 5 millimeters of mercury, which is significant in terms of therapy and diagnosis. 16 out of 19, 84%, resulted in increased diastolic blood pressure. And a further study by Piccone demonstrated that a 5 millimeter over or under measurement of blood pressure may result in misdiagnosis of 48 million subjects in the US alone. So once you get down to making errors greater than 5 millimeters of mercury, then it has significant consequences, both from a therapeutic point of view and an outcomes point of view. If we go forward, we know that although it's the most common clinical investigation that we conduct, it's not simple. It's rarely conducted according to guidelines, and there are multiple sources of error. So these are the explanations, if you like, as to why both the value for hypertension may not, or the value for blood pressure may be misleading, as well as complicating our choice of therapies. Another further technologic observation is that most devices that we buy, and we buy blindly on the assumption that these devices are regulated and controlled by all the regulatory authorities of the CE, NMPA, TGE, and NMPA, etc. The truth is that generally there is no requirement for them to be validated. And in fact, the vast majority, 76%, have no validation at all. And this was in an assessment of 3,411 devices that were on global sale. And the implications that has for the reliability of blood pressure monitoring is significant. Less than 10% were validated. What we do assume too is that there are valid methods of validation, and invasive blood pressure measurements with catheters, intra-aortic catheters, are considered to be the gold standard. But the truth is, we actually don't know what the pressures are. Both invasive measures have flawed methodologies with them, as do non-invasive. Any method that we have, there are significant variabilities related to operators, technology, interpretation, etc. Let's revert now back to the inner canon of the Yellow Emperor and his proposal or observation that the pulse equals the heart times the chi. It took Western medicine until 1955 when Arthur Goten defined the heart and the chi as being stroke volume, heart rate, and systemic vascular resistance. And this is a key connection, if you like, for the hypothesis as to how we can better understand hypertension, and that's pathophysiology. No longer do we need to look just at blood pressure alone, but we start looking at the heart and the vessels independently. If we look at the pathophysiology and hemodynamics of blood pressure, what we can see is what are the underlying derangements that we measure with blood pressure that indicate pathology and abnormality. And what we can see here is that we can identify these pre-hypertensive states, and what they are is compensated vasogenic and compensated cardiogenic circulatory dysregulation. Now, once we exceed the points of compensation, we then become hypertensive, frank hypertension, and the dysfunction of the circulation is represented as a change in blood pressure. So what you can see here is that it will be very difficult for us to understand and manage pre-hypertensives, even though we suspect that these are the folk who have the most likely therapeutic benefit from intervention. So it's a focus on these people before their baroreceptors re-establish new set points. That is really a very important therapeutic approach. Now let's look at the overview of the stroke volume, heart rate, and systemic vascular resistance. These are the targets, and it's the hemodynamics that we target with fluid inotropes and vasoactives, the basic or the fundaments of hypertensive management. And yet we monitor and treat blood pressure, but we ignore the hemodynamics, even though we treat them. This is fundamentally unscientific. What we need to be doing is to look at the hemodynamics to understand both the underlying pathophysiology and what the therapeutic opportunities might be. What do we do in hypertension? We reduce the hemodynamics, ACE, ARBs, CCBs, and thiazide. These are a standard fare in various mixes, depending on underlying comorbidities, for treating hemodynamics. Each of them affects the hemodynamics. So how do we measure the hemodynamics? And this is the key. Recent sort of developments have allowed us to look more closely at the hemodynamics. And I love this slide because it reminds me of the power of the stroke volume, the function of the circulation and the respiratory system, and gives me a physiologic foundation for identifying what are the things that are really important for the organism. And it is the stroke volume, cardiac output, systemic vascular resistance, and oxygen delivery. It's a powerful tool. Now, recently, specialized devices have evolved to provide beat-to-beat, instantaneous, simple, accurate, reliable measures of stroke volume, cardiac output, etc. And this has opened the door for us to understand, and this is what I've spent the last 10 years doing, looking at hypertension from the point of hemodynamics. Once you get that stroke volume and you get it auto-traced, you get a beat-to-beat measure of 22 real-time parameters. And arterial compliance, elastance, oxygen delivery, stroke power, cardiac work, etc., are all powerful predeterminants of cardiovascular disease. So we're gaining an insight. Once we plot those numbers, and this is a normal nomograms that I've assembled from an enormous number of normal individuals. And what we can see here, and this supports the concept of precision, and that is absolute values are not so useful in cardiovascular medicine because the variability between individuals is very high. Your standard deviations for multiple measurements is very high. But once you have a reference point, then the sensitivity to changes within each individual, which is sensitivity and specificity, is high. And so from the point of view of the pathophysiology of hypertension, you've got stroke volume index that's high, then you give a diuretic and or a negative inotrope and monitor it come down. Or if you're a vasogenic hypertensive, systemic vascular resistive index, then a vasodilator. Plot shifts your reference measure and is a trend indicator of your ongoing disease or resolution. Put a little more simply, fluid diuretics reduce stroke volume and cardiac output. You get an autonomic compensation to some extent with an increase in your SVR. And negative inotropes, of course, reduce SV and CO again, and you get an autonomic upregulation of the SVR. And vasoactive vasodilators, in the case of hypertension, reduce your SVR and you get a slight autonomic increase in your SV and your cardiac output. So this is just a publication that's in preprint at the moment, which is coincidental to this discussion, but it summarizes what are the three major points of pathophysiology. And one of the things that I did in this paper was to actually examine 9 global cardiac hypertension guidelines. And I did a word count on the number of times that cardiac output, blood pressure, and hemodynamics, or hypertension, blood pressure, and hemodynamics were mentioned. And as you can see, hemodynamics was virtually ignored in preference for BP and hypertension. So there's a physiological imperative. So we've got a clinical imperative. We now have a physiological imperative. And what we can do is say current BP-led approaches to hypertensive management are substantially ineffective. And that's a strong assertion, but the data is very clear. Less than 25% of those people who have hypertension are treated with blood pressure control effectively. That says there's a clinical need for an improved approach to diagnosis and management of hypertension. Hemodynamics-led concepts for management of hypertension are physiologically and therapeutically rational. The adoption of such concepts of precision therapy may improve clinical outcomes in this pandemic condition. And again, looking to history to receive some sort of endorsement for our approach, it was Confucius who said, when it's obvious that the goals cannot be reached, don't adjust the goals, adjust the actions. And so thank you very much for allowing me to introduce these concepts and ideas about precision management. It's obviously a new pathway for hypertensive management, and we look forward to the opportunities to improve care and improve outcomes. So thank you very much for the opportunity to present to you today. Thank you.